Welcome to Still a Part of Us. We are very excited for today. As you can see, I've got Lee with me today, and we've got a couple of other guests to talk to us. And we have a couple of really special people on the show. And first of all, we have Dr. Bob Silver. Just a little bit about him. He is a national expert in high-risk pregnancies, seeing patients with pregnancy complications at the University of Utah. He specializes in stillbirth, pregnancy loss, placental problems such as preeclampsia and fetal growth restrictions. He does oversee research specifically on stillbirth, pregnancy after loss, immunological diseases in pregnancy, and other medical disorders you might find in pregnancy. Now, I just want to show the extent of what his work is, but he has done a lot of research. And in fact, he has published more than 400 peer-reviewed publications in many journals. And he was our doctor for the pregnancy after Brannon's stillbirth, our son that we lost to stillbirth. So we're so excited for him to come on and talk with us a little bit more about what he does. And I also wanted to introduce Sarah Lopez. She has been working in research since 2016 at the University of Utah and working specifically in stillbirth research since 2018. And she has been very integral in developing their stillbirth program at the University of Utah. And since I work in research, I've worked with Sarah for a number of years. So it's actually really fun for me to be able to talk to her in this capacity than just being, colleagues and, hey, where's this consent form or anything. So I'm so grateful that she's willing to come and chat with us today. So welcome to both of you. We're so glad you're here.
Thank you. Thank you so much. It's a pleasure to be here, and it's great to see you and your family.
Thank you. Well, we wanted to have you on because there was a lot of I don't think people realize how much work you guys do in really trying to figure out what are the causes of stillbirth, and actively trying to ease that burden for the people that that have had a stillbirth in the past. So before we get started, I actually want to ask really fast, Dr. Silver, if you wouldn't mind, can you just explain to us and to our audience what stillbirth is and how is it defined medically, just so that we have kind of a basis to go off of?
You bet. That's a great question, especially since there are many different definitions in use. Mm-hmm. But stillbirth is the loss of a baby prior to birth. So it can happen prior to labor or during labor. And in the United States, we use the definition of any loss of a pregnancy after 20 weeks, which is about halfway through the pregnancy. In other countries, there are different definitions.
Oh, okay. So, but in the United States specifically, it's 20 weeks, and it could be before or during the birthing process.
You bet. I think it's really important to note that we don't want to get too hung up in these different definitions because every pregnancy counts and every pregnancy is really meaningful to families. Yes. But by using some of these terms, it can help us get smarter about it and learn how to prevent losses at all stages and ages. But because losses happen for different reasons at different times in pregnancy, that makes using a definition like this valuable.
I greatly appreciate that you are talking about how each loss is very individual to the parents and also to you as a provider, and how it's good to have the definitions of what stillbirth is so that we can then quantify it and then study it. I guess maybe I should ask, what are some other common misconceptions about stillbirth, and what have you encountered with these misconceptions? And
I'll defer to Sarah to start with this one.
Yeah, I think the biggest misconception I see is that it doesn't happen in the US. That's usually everybody's first comment after they have one is, I didn't know this was still a thing. I didn't know that this could happen to me in my pregnancy. And I thought this was very much a thing that only happened in lower resource settings. And so I think I would have to say that's probably the biggest misconception is that it doesn't exist anymore, but it definitely does. So.
Yeah, even as being in a first world country, right? You just don't expect it to still be so prevalent. So yes, I totally get where you're coming from with that.
You bet.
And there's a stigma. Yeah, there's a stigma around it. People don't feel like they can talk about it. And so because of that, it kind of goes under the radar. It does happen to people around you. They're just not talking about it, unfortunately. So go ahead, Summer.
You bet. It's really common in the U.S. It happens about 1 in 170 pregnancies, and it's something that parents often don't even consider as a possibility until it actually happens to them. And so we're trying to be better about communicating that to parents, not to unduly scare them, but to have them be prepared for possibilities. A couple of other important misconceptions. One really big one is that there's nothing that you can do to prevent stillbirths.
Hmm.
That it's just God's will, or it's just, going to happen no matter what you do. And based on pretty conservative estimates, at least 25% of stillbirths are preventable, and likely a lot more. And the proof of that is the dramatically lower rates of stillbirth that happen in other countries. So there's no question that we can get better. Another really important misconception that I think is really important for families is that stillbirth is almost never linked to the behavior of the parents. And whenever anybody experiences a problem with their pregnancy, it's just what humans do. People blame themselves and they wonder it's because I was stressed, or I exercised, or I had sex, or I had a beer, or I should have done this, or I shouldn't have done that. And parents should really be reassured that stillbirth is almost never caused by any behavior or failure of behavior on the part of the parents.
I want to emphasize what you just barely said, because you don't know how many parents we talk to, and there's always some blame that they put on themselves for doing this and this and this and this, and they just are racked with guilt. And so for you to say that is, it's a burden off of our shoulders. I blamed myself for sure after we lost our son, for one reason or the other. And so thank you for saying that. Thank you for pointing that out as a misconception, everybody. It's a misconception. So, can I ask one question? Because you mentioned something about how in other countries that the stillbirth rate has decreased. I mean, like, you can see that the trend, it goes down. Because some of those things are preventable. So can you tell us, data-wise, what's the past 20 years? What are the trends in stillbirth? Has it gone down? Are we doing better in the United States, or is it just in other countries? Can you give us a little bit of an idea of how we're doing in regards to the stillbirth rate in the United States and compared to other countries?
You bet. So it depends on which countries we're comparing ourselves to. And in the most recent rankings, we had the 27th best stillbirth rate in the world, but that's much lower than many countries with similar resources. Now, if it's important to note that the statistics that are used to compare countries tend to be stillbirths greater than 28 weeks. And that's simply because there are better data. The further along you are in pregnancy, the easier it is to capture and to be more accurate about it. The earlier in pregnancy that somebody has a loss, the less likely we are to capture that information. Mm-hmm. There's some good news to the stillbirth story. If you go back for 100 years or 200 years, then the rate of stillbirth has dramatically decreased throughout the world, and dramatically decreased in the US by 100-fold. So a lot of medical advances have really improved stillbirth rates. Unfortunately, they've been plateaued in the United States. There has been a very, very, very slight decrease over the last 10 years, but so slight that it could be statistical variation. But up until about 20 or 30 years ago, there was continued progressive decrease in the United States. So we have hit a bit of a plateau. In contrast, other countries, even high resource countries, have continued to have a decrease in the rate. Now, the most dramatic decrease in the rate has been in countries with fewer resources than us. and they have much higher stillbirth rates. And so there's much more opportunity to lower the stillbirth rates.
Yeah.
So dramatic decreases have been shown in places in Southeast Asia and Sub-Saharan Africa because the rates were so high. But even other high-resource countries have had more rapid rates of decline than in the United States. And to put that in perspective, out of 150 countries, our rate of decline of stillbirth is one of the worst.
And that is why you guys are doing research, right? To figure out what this disparity is, I suspect.
Yes, I mean, another illustration of this is the Netherlands, a country with very similar resources, had a 6% decrease in the rate of stillbirth, even though their rate was lower than ours to begin with. And our rate of decrease has been 0.2%.
Oh,
So we are getting better, but very slowly. So I would point to the success that's occurred in other countries as being pretty good indirect evidence that we can do better.
Yeah, for sure. That's a big difference. Like 6% versus, like you said, 0.2. That is, I feel like that's a big difference there. So I do want to get into a little bit more of the research that you guys are doing because I have an interest in the research. I think it's really wonderful. And so can you tell us some of the recent advances that is happening in stillbirth research? Maybe Sarah, you can talk a little bit about some of the things that you are very much participating in because she is a coordinator for all of these things. And so she sees all the things and she talks to the parents that she interacts with that have experienced stillbirth. So can we chat about a little bit about the research?
Yeah. So up at the U, I have a team. And so we do about 30 different research studies, all related to either pregnancy loss or stillbirth. And a lot of them are observational. We're just trying to gather data, collect data, try to see and understand what's going on underneath. But I think the biggest advancement that we're really looking at is whole genome sequencing. It's a newer test, so we're still not quite sure what it's going to tell us, if it's going to give us answers. But what we're doing right now in this really cool study is we're looking at mom and dad's whole genome sequencing, but then we also get samples from their living children, and then we can actually go back and get samples from placental tissue from your loss, as long as it went to pathology at some point. So even if your loss was 15, 20 years ago, we're finding that if you have a placenta formalin block, we can get really good DNA extraction out that. And what we do is we kind of compare them all together, see if there's reoccurring genes, see if there's any new emerging genes that are incompatible with life, just to see if there's a genetic way to explain kind of what's going on to help give parents answers. So I would love to have Sega be on one time. He's our neonatal geneticist epidemiologist, and he knows way more about it than me, but it's really cool. And I think it's a really cool next line for parents.
That's really cool. So I'm actually a little curious. Can anybody participate in that? Like any families? Is it just people that are in Utah? Is it all over the country? I'm like, should we sign up, Lee?
So yeah, it's actually across the US. So anybody can do it. We can do it remotely. We can do e-consents remotely. So like on Zoom, we can talk, and then I can just ship you out like saliva kits and have you like sign a release of information. So we can get some like clinical data from your pregnancies. But there is a little bit of limited inclusion exclusion criteria. So right now we're trying to focus on people that have had more than one loss, so 2 or more losses greater than 12 weeks that are otherwise unexplained. So if you have like an underlying condition that kind of explains like antiphospholipid syndrome, you may not be a very good candidate for this because we already know what's going on. So we want to focus on those parents that have had multiple reoccurring and unexplained, though we are hoping in the next year to open it up to anybody that's ever had a loss. So hopefully that will come soon. But I can actually send you a flyer too that you can share if you want. If people are interested, they can reach out to me and we can sign them up.
We would love that. We'll be happy to share that information because I think just having data and also just like you said, taking a look at the genes a little bit more carefully with a lot more data, that's where you'll start to see the trends, I think. So I think that's cool.
Yeah. Mm-hmm. Anything else to add, Silver? You're kind of like our all research guy.
We're we're doing many research projects to try to, reduce the risk of stillbirth. And it's complicated to do the research for many reasons. Number one is stillbirth is a relatively uncommon condition. So to show a reduction in stillbirth, you really have to enroll a lot of patients in a particular study to show a reduction. So that makes it a little bit harder to study. One of the strategies to help with that is for us to partner with other folks, and we're doing a lot of that. We have a pretty good network throughout the United States, and maybe later on I could talk about some new things that are going on. And we also have a network internationally, but that makes it a little challenging. The other thing that makes it a little challenging, but also makes it easier and even more important, is that there are many different causes and contributors to stillbirth. It's not a single disease process. And we didn't talk about it during this episode, but a lot of stillbirths are due to problems with the placenta. The placenta is the afterbirth, which provides blood flow, oxygen, and nutrients to the baby. And if that doesn't develop normally or that becomes damaged, then there's an increased risk of stillbirth. But there are many other contributors to stillbirth. Preterm labor can contribute to it. Certain infections contribute to it. Certain genetic abnormalities can contribute to it. Maternal medical problems can contribute to it. Problems with the umbilical cord. So because there are so many contributors, that makes it also more challenging. But it also means that trying to help reduce stillbirth has impact way beyond just stillbirth, because the conditions that cause stillbirth also cause live babies to be born with medical problems. And so our work that helps reduce stillbirth can also cause babies that aren't going to be stillborn to be healthier as well. And so it can have even more impact. And so we can study each of those contributing conditions and then try to reduce the adverse outcomes of those conditions, where stillbirth might be the worst case, but even not the worst case still causes babies to be sicker than we wish they were. So that's one of the challenges. And there's no single simple solution. It's not like we can just create one pill that's going to be a stillbirth pill. So we have to do all kinds of different studies and study each one of these contributing factors. So, and then another way to catalog the stuff that we're doing is there are ways to reduce stillbirth with knowledge that we already have. And if we simply were to do what we're supposed to do every time we take care of patients, and we did that perfectly, many stillbirths would be prevented. And some of them could be prevented with the knowledge that we currently have. And then there are some stillbirths that, if we want to prevent those, we have to learn new things that we don't already know. So you can divide our research into those two areas. So we're doing lots of clinical studies on large groups of patients to try to predict the risk of stillbirth. And those who are at higher risk, we can then do additional testing or consider delivering their babies a little bit early. And then those who are at lower risk, we feel comfortable doing less testing and not delivering their babies as early. And in order to try to differentiate between those groups, we're doing things like, in addition to the normal medical history that we take, we're trying to measure different things on ultrasound, and we're trying to measure different proteins that are made by the placenta or made by the baby that can help us predict stillbirth risk. That's a major effort in a lot of what we do. Another major effort is trying to more precisely define the causes of stillbirth, and this is where a lot of the stuff that Sarah told you about comes into play. So those studies tend to involve patients who have been through a stillbirth. But we're also doing a lot of studies on the general pregnant population in order to predict and then prevent stillbirth. We're also doing a lot of studies on how to build a better placenta. Are there medications that can help the placenta grow and develop better? Or are there medications that can prevent damage to the placenta, either from inflammation or from blood clotting or things like that? We're also doing a lot of studies to try to study the function of the placenta. The technology keeps getting better, and so our ability to image the placenta and blood flow of the baby is much better. And so that's a major part of what we're doing. And then a big part of what we're doing is trying to do a better job of providing emotional support for families. It's recognized that stillbirth is a traumatic experience, both when it happens and then in the aftermath. And then also when people get pregnant the next time, there's PTSD. And so instead of just kind of doing what seems to make sense, we're trying to ask families what helps you, what works, what doesn't work, trying and scientifically testing different approaches. So what is the best way to help support families to get through this, and what do families need from us in the future? And that's something that we haven't done enough of. So I could talk about research all day, but we just want to share our excitement about this, because we're really optimistic that this will ultimately lead to helping families get through it when it happens, and B, helping there be fewer stillbirths in the future.
Now, you talked about how in your research, there's many avenues. You're researching the placenta, you're researching the genetics. How are you implementing these new practices for the patient and also care for the providers, for the doctors? How is the community getting all this new information that it can then help prevent stillbirths?
Another great question. I'd love to answer that question, but I'm going to ask Sarah to start, because one part of this is a workshop that we're going to be hosting shortly.
Yeah, so I mean, that's always the biggest challenge of any clinical research, is taking it from the research and then putting it actually into practice. And a big part of it is just making sure that clinicians have the resources they need and are educated on the most cutting edge things. So one workshop that is actually developed by Australia, they have a Center of Excellence down there in Brisbane, led by Vicky Flannery and a couple of other wonderful internationally known researchers. And they created the Improve Workshop. And now this workshop is really focused on, helping families after a stillbirth. So it's not so much focused on prevention, but it's really focused on the investigation of a stillbirth. What is the best practices for, doing a full workup to make sure that you've exhausted all of the potential resources to give parents the answer, right? What are the maternal labs? Have you looked at the placenta appropriately? How do you support this family bereavement wise? And there's also, how do you classify this death, and how does that lead into other epidemiological data down the road? So it's a 6-part workstation that everybody goes through, and it's about 20 to 25 minutes per station. But it's delivered by the experts, the leading experts in this field on it. And so we're really excited to bring this to the US. This will be the first time it's done in Utah. And what we're hoping to do is have the Australia team is actually going to train a US-based team. So that way we can then provide this training throughout the US going forward over the next several years. So that way we can go to lower resource settings like the Fort Defiance Reservation down in Arizona, and go give those providers the support that they need, because these providers want to do better. They want to support these families, but a lot of times they just don't know how. And so that's really the goal of this workshop. And so, there's still plenty of room to sign up. We have a Monday slot that people can sign up for. So we encourage midwives, nurses, NPs, PAs, you name it, to come attend. And I think it's a very helpful workshop to create discussion. And it was also developed with parents' voices incorporated. And I think that's really important too. It's not just based in research, but it's also been run through parents that have experienced this, so that we know we're giving the right care to the patients that they need.
Is the University of Utah the pilot program here in the United States with the help from the Australian program?
Yes. So we'll kind of house it But we're going to have a bunch of clinicians from all other institutions be educators. So we're hoping to have like an East Coast based team and then a West Coast based team. And we'll just kind of coordinate. Hopefully, we're hoping to do one workshop a year in a different place. And so it's really up to institutions that want to provide it too. They can reach out to us and then we can work with them to get all of our educators there and deliver that care to the clinicians at that institution. And a lot of this is voluntary by the educators. So they're not getting paid to go do these workshops. They're kind of donating their time to help provide this education to other clinicians.
I think this is really exciting. We are signed up. I'm signed up to actually attend the workshop just so I can see what is happening on the other side, because I even though I work in healthcare, I'm not in that field necessarily, but I want to know what kind of care is going to be given for our folks here at the University of Utah that come in, patients that are seen there. So I'm looking forward to it. So I recommend, I encourage people to sign up if you can, because you have no idea how much, like those nurses, they made the biggest difference to us. And even the ultrasound technician, like when we got the news, it just, having that little bit of care and understanding of what we might be going through makes a huge difference. So I encourage people to join if they can, if they're in that space to do it. So thanks for sharing that.
Yes, and it's a great time for us to help dispel a lot of misconceptions around like autopsy or stillbirth workup.
Yeah.
We still hear from providers that they think autopsy isn't beneficial, and that's just not true. And so we really need to get that information to the clinicians that are going to be seeing patients after they have a stillbirth, so that way we can get better workups and hopefully better answers for the parents.
I am wondering if you guys can speak a little bit more, because I got a little bit of word of something called the Safer Baby Bundle. And I, for some reason, thought it was an actual physical something or another. And so when I started looking into it more, I thought this was this program. And I think it was it developed in Australia as well? So can you talk a little bit more about that and how you as a provider, Dr. Silver, you try and implement this with patients and other clinicians so that we can get these babies here alive and healthier?
You bet. That's a great question, and it doesn't have a simple answer.
Yeah.
And one of the complicating features, and getting back to the last question that you asked, is that our healthcare system is more complicated than some other countries because we don't have a standardized practice across our country. And so the concept of a bundle is simply, instead of just one intervention, like we're going to have people take aspirin, it's a series of interventions, 5 or 6 or 7 or 8 things that are all intended to have an impact on a disease, and they're all linked together, and that's what a bundle is. And there's pros and cons to that. The pros are that you're doing everything that you can possibly do to favorably impact a medical problem, and that's great. But the cons are it's not very scientific, because some components of the bundle may actually be harmful, and some may be useless, and some may be helpful. So in an ideal situation, you would want to just do the components that are helpful, and certainly not do the components that are harmful, and probably not even do the components that are not helpful but not harmful, because they're not cost effective. So it's hard to study the impact of bundles scientifically. But that's what a bundle is. And in the United States, it's harder to implement bundles. It's harder to change medical practice, because the two countries with bundles who are good countries to use as examples because they have lower stillbirth rates than we do are the United Kingdom, England, but really the policies used in England are also used in Scotland and Wales, right, and Northern Ireland, and also Australia. And those countries have a national health system. And so a policy can be implemented and adopted by everybody in the country after appropriate debate. But in the United States, we have no such thing. And so different healthcare systems can have different policies. And even different hospitals within healthcare systems can have different policies. And even different doctors in the same hospital can have different policies.
Yeah.
Yeah.
So it's really hard to get things adopted. We do have authoritarian organizations that can make recommendations for policy, but they're only willing to make recommendations when there's very, very strong scientific evidence to do so, and when there's very little risk of harm. And so that's been a controversy regarding the bundles. And so the bundles that have been done in Australia and the UK seem to be helpful, but they haven't really been proven to be helpful. And some of the components of the bundles are things that we're already doing in other ways in the United States. And some of the most controversial components are not clearly helpful and have the potential to be harmful. So there's been resistance on the part of people in the United States to make these recommendations. But the failure of people in the United States to make these recommendations has really been hurtful to parents who have experienced stillbirth. And it's really been frustrating to people who are passionate about reducing stillbirth in the United States. And I think there's a precedent set in the United States for adopting bundles, even if it's not scientifically proven to help. And that precedent comes with maternal mortality. We have moms dying at a higher rate in the United States than in other countries. And that was considered to be such a bad thing that we adopted several bundles to try to reduce the risk of maternal mortality, even though they weren't 100% proven to be effective. But when faced with the same situation with stillbirth, which is far more common than maternal mortality, we haven't taken that approach. And so I personally would like to see us be more aggressive with it. And I completely agree that we have to be evidence-based and we have to be as scientific as we can be. And we need to study the effects of each component of the bundle because we want to do things that are helpful and we don't want to do things that cause harm. And we don't want to waste people's money or create anxiety. But we also are faced with doing the very best that we can today. And babies are dying while we delay in doing something. So I think that we can adopt at least some components of these bundles that are most strongly supported by data. And we're trying to advocate for that. But it's more complicated in the United States. What we have to do is lobby these not authoritarian, but these authorities, these national organizations that make recommendations, and then that will influence health policy and then be adopted throughout the country. Some of the components of the bundles are not controversial at all and clearly beneficial, like reducing smoking, optimizing weight, good nutrition, good prenatal care, and those kinds of things. But there are some components of the bundles which are more controversial. Position for sleep. There's some evidence that sleeping on your left side may increase the risk of stillbirth, but there's some evidence that it may not matter and it may create anxiety and self-blame. Decreased fetal movement, being more aware of decreased fetal movement and more thorough in evaluating those patients may be helpful, but there's also some evidence that may actually cause harm because decreased fetal movement is so common and nonspecific. And so that's another area of controversy. Another area of controversy is routine ultrasounds in the third trimester. So I'm hopeful that we can come to a middle ground where we can adopt some components of the bundle and then study those components that we're less certain about. I'll also say that sometimes just acknowledging that a problem is really important and trying hard to address that problem has value. And when you measure something and people know you're measuring it, that measurement tends to get better almost no matter what you do. And if you're not paying attention to that problem and you're not measuring it, you don't tend to get better. And also for parents out there who have experienced this, us not paying a lot of attention and not trying to be better feels hurtful. And us acknowledging it and trying to do better feels better than that. So I would love to see us do a bundle, but it's controversial and because of the perfectly justified and understandable desire to not cause harm.
Yeah, so regarding the bundles, I don't think I realized that there were some things that were controversial or is not as well backed in science. So I'm curious, do you know of any of either the UK or in Australia, are there any active research studies happening to see if those bundles or components of the bundles are effective or are more beneficial than harmful? For example, like you said, decreased fetal movement, for example. Because I know that in the United States, there's the Count the Kicks organization, and they're very much into encouraging people to count the kicks, a movement of their baby while just on a daily basis, so they can track that. So I'm curious if there's any data or if there's anything that they're doing it so that in order for it to be something that is eventually approved by some of those governing bodies in the United States to be adopted as policy in the future.
You bet. So there's a lot of active ongoing research and all of the above. So firstly, it's not a very good study design, but people in the UK and Australia it's a very simple study design, which has a lot of bias, but they're basically saying, what was our stillbirth rate before we instituted the bundle? And then what's our stillbirth rate after we instituted the bundle? And you can conclude that if the stillbirth rate goes down, the bundle may have had a favorable effect. It's not as rigorous as you'd like science to be, but certainly it's more likely to be true if the rate goes down, and it's less likely to be true if the rate stays the same. So that's being done.
Yeah.
It's hard to study the individual components of a bundle doing that kind of study. But we are in the process of trying to do more complex studies where every patient that comes in with decreased fetal movement is evaluated and their data are entered into a computerized database and they participate in the study so that we can better assess what risk factors are associated with adverse outcomes and what testing is associated with better outcomes. And right now, when people have done studies to try to prove that counting the kicks or assessing decreased fetal movement is helpful, they haven't been able to show a benefit in study. And if you put all the studies together, there has not been a benefit. There has been a trend towards a benefit. So there's enough of a signal that it makes sense to keep studying it, but they haven't been able to show a benefit, and there is the potential for harm and the reason is decreased fetal movement is so common among normal people having normal babies. And so if we deliver babies preterm, they can suffer medical problems from being born early because they're not fully developed. And so if you have somebody who's a few weeks before their due date, if you have a 1 in 3 risk of stillbirth, the risk of a small amount of prematurity is well justified to prevent that stillbirth. But if you have a 1 in 3,000 risk of stillbirth and you delivered 3,000 babies early, you'd probably lose more babies than you would save. And so we have to get better at separating the babies who are really sick when mom has decreased fetal movement from the babies who are perfectly fine. And so we don't want to overreact by saying decreased fetal movement is useless and we're not going to do it because it hasn't been proven to work. And we also don't want to overreact in the other direction and say we're going to institute these policies where we're going to, do this with everybody and maybe cause harm. So that's an area of active study.
Yeah.
So there's a combination of studies. One is let's do the best we can day to day with the patients we have, and let's track that and try to learn from it. And then let's do some new studies where we try to get smarter and then do different things that we don't know about.
I think that's actually, I'm so glad that you walked through that because it feels like we don't consider on the other side of, once that baby's born, I mean, if the baby's really premature, that could cause lifelong issues, even if they do survive. So it's a fine balance. And I remember having that discussion with you when we were having a talk about when we were going to get induced with our son Felix. And I appreciated the discussion we had of like balancing the risks of delivering him too early or versus the risk of him being stillborn. So I appreciated you going through that with us when we were having that discussion at that time.
When we were freaking out.
Yeah, when we were freaking out, because we were freaking out. So,
I mean, and that's an incredibly important thing because parents become so anxious. And if you're born early, you may suffer medical problems, but you're not going to be stillborn.
Yeah.
And so for parents, that makes perfect sense. And it's tough because you know the emotional duress that parents feel also has a lot of value and is really important. And so we wouldn't want to take a major risk of causing harm through preterm birth. But say you're very close to term and you took a very minor risk, that might be a risk that parents want to take and think and it's worth it to them. And so those are great discussions for families to have with their providers.
yeah. And I think that just that's the key is just being aware of just talking and advocating for yourself. So I wanted to close with one question for both of you. And because I felt like we received a lot of support this way, but how does your team work to support families that have experienced stillbirth? And I know that there's a lot of resources. So I would love for you guys to talk about the resources that you guys provide, as well as things you do as you interact with patients on a daily basis that have experienced stillbirth and coming back in with a pregnancy after loss. How do you guys support those families, and what have you found to be
I'll
beneficial?
let Sarah start and then I'll just fill in if she misses anything, which she won't.
Okay. Oh, I'll try. For us, one of our studies is our prospective stillbirth study. So a lot of times we're going into the room, sometimes 15 minutes after the family has just found out their baby has no heart tone anymore. So as you can imagine, it's like an incredibly high emotion, very traumatic situation for them. And then we're walking in asking them to do extra things. So for us, one, we always go in with the understanding of like, you can be as rude as you want and tell me to get out at any point. At any point you don't want to listen to me anymore, just say the word and I'll leave. And that's how I always start. But then two, I always ask, what is your baby's name? And I think that, and then I use their name throughout the whole interaction. And I take care to go, I hold their baby, or I ask them, hey, can I hold your baby? Is there, and I kind of talk to the baby too a little bit, which I know some people might find very weird, but I think it's very validating that to the parents that this is a baby, this is your child, and I want to respect that, and I want you to know that I respect your baby, because in research, I'm always so impressed with women's willingness to do this, even though it might not directly benefit them. They do it because they are hoping that it will benefit women in the future, so that if they can save one other mother from having to go through this. And so I just want to reassure the parents that, research is here and we understand the depth of this trauma, and we want to support you and we want to help you get answers. We're not just some people like grabbing samples or just throwing data away around and not understanding what it means. And that we're just so grateful to these parents that are willing to do extra, because research isn't mandatory. They can opt in or out, and they're willing to do that. And so that's what I always train my staff. That's the big thing, is to just make sure you're treating that baby with all the respect, and then offering up to them to all of the resources. I almost always give out Dr. Silver's scheduling information, because I say, hey, you might not be ready now, but you might want to have a baby in the future. And it's hard going through that rainbow pregnancy, or that pregnancy after a loss is very hard, very traumatic, very anxious. And so I just want to make sure that they understand that there's people that specialize in this that can help you through it. There's a lot of other resources, even outside of the hospital doors, because I feel like that's what usually happens with providers is, they can give all the resources inside. We can have a social worker or a psychologist meet with you, but as soon as you step out that threshold, you're just out in the community. And so I always try my best to connect them with community resources too. So like in Utah, a big one is Share Parents of Utah. And that's a not-for-profit that is ran by women that have experienced losses themselves. So either it's a child death, a neonatal loss, a stillbirth, early miscarriage, whatever. And so that way you don't feel isolated. There's other women that have gone through this. There's other parents that have gone through this. They're really good about connecting dads too, because I think dads get a little overlooked, unfortunately, while we're focusing on moms, physical health and well-being. Dad is sometimes the silent, strong one trying to keep it together for mom. And so making sure that they have resources too is really helpful. But then also just reassuring them, hey, we're doing research. We want to understand this and give people answers. And we have a couple of advocacy opportunities too. We have the Stillbirth Advocacy Working Group that Susanna Lesher and myself and a couple other wonderful women started about a year ago, actually a year this month. And it's women and dads and parents and researchers and clinicians, nurses, I mean, you name it, all over the US. And we meet once a month, and we have a couple of initiatives every month to go over advocacy and how we can, one, make sure people understand that this still happens in the US, but then two, also move some legislative pieces and also give parents in different areas resources to do, grassroots policy or legislative things to help in, their states or their local communities as well. And so a big one is the Safer Baby Bundle. Silver is involved in that too, and we're trying to advocate for that. Another big initiative is the Shine for Autumn Act. So this is a piece of legislation that's up on the Hill right now, and it's basically going to dedicate funding. I think it's like $9 million over 5 years, specific to creating a more robust database across the U.S. that all researchers can access, that has better demographic, or not demographic, but like better detailed data that epidemiologists or researchers can access to see trends across the US. And we're trying to include environmental factors in that too. What does pollution mean for that? What are the local resources? We need to be able to see the whole picture with all the pieces of puzzles together. And right now we don't always have that. So Shine and Autumn Act is going to be really key in helping us restructure it at the national level to make sure we're all on the same page. So that way, that's a great launching point for all research across the US, not just locally in Utah, because again, like Silver said, the numbers are small. It's a rare thing. So we really need to look at all of the US to get those numbers. If we're just looking at Utah data, we're going to be a lot more limited in what we can tease out. And another big part of the Shine for Autumn Act is to get more perinatal pathologists in the US. So getting more people into those residence and fellowship slots, because we have a shortage of those globally, actually, but it's really bad in the US too. We're very fortunate. We actually have 2 in the state of Utah, but they also help cover all of the outside states too. But it does get complicated. Like Wyoming doesn't have one, Idaho doesn't have one. And so you don't have a pathologist that specializes in stillbirth or neonatal loss. And so if it goes to a general pathologist, they're not necessarily going to entirely know how to approach that the same way a perinatal pathologist would. So we really want to make sure we're getting those slots filled so that we have people to properly investigate the stillbirths as well. I feel like I just rambled. Silver, did I miss anything?
No, you got most of it. I think it's really important for families to know that this is very emotionally stressful, and that you can get help to get through the bereavement part of this if you have depression or anxiety, and then help in the next pregnancy. And so we have great resources with mental health care workers. A lot of people seeing professional therapists is the best thing to do. And we've got great resources if you contact us. There's also great peer-to-peer support. There are many support organizations, and a lot of people work well that way. A lot of people prefer one-on-one communication, but just knowing that you're not alone and that other people have been through the same thing. And sometimes nobody understands what you're going through the way that other people who have been through the same thing understand it. And then as clinicians, we can support you in a subsequent pregnancy. Clinics like the UPAL clinic, where not just the providers, but all of the MAs and the office staff and the people who do ultrasounds have all been trained in the best ways to provide emotional support for patients. And we're trying to get these clinics into as many hospitals and as many healthcare systems as possible so that they'll be available for everybody.
And the UPAL clinic is for, at least for the Utah, University of Utah, is the Utah Pregnancy After Loss Clinic. And That is really very new for us. And I think, Sarah, you can maybe speak to that, but it's a place where there is a lot of support for those who have suffered a stillbirth or an infant loss, and they just want a little bit more. They need a little bit more support during that next pregnancy.
Correct. Yeah. And this is care Dr. Silver has been giving for many, many years. But then we kind of realized we're like, oh, we should make this standard across multiple physicians and really dedicate a clinic to it. And so that's what we did over the last year we talked to parents. We have a couple of parents that help us with our Center of Excellence and really got their input. What's helpful? What's not? And we actually had a stillbirth parent. Her name's Stacy. She's fabulous. She works with us all the time. She actually created this training for our clinicians and our MAs and everybody else. And so it was from a parent that has experienced that is delivering the training. And I think that's really important to make sure that we have that parent voice involved. But yeah, and we're doing peer-to-peer support with that clinic. So that way they have the moms coming through this clinic, they have a parent that's been through this readily available if they need it.
Yeah.
And we can do mental health check-ins and give them immediate support right if they need it. Because that next pregnancy is hard. It's so hard.
Yeah.
You're so anxious. You think it's going to happen again. And, it's just stressful. And so giving you all the support we can possibly give is our number one goal.
Yeah. That is huge. And I appreciate Dr. Silvers, especially since he was our provider, and he was just so reassuring about everything was going to be fine. And so, like he said, he provides that care anyway because of his background in that. I apologize for Lee. He had to step out and take care of our son. He was hollering at us from the other room. So, but I wanted to thank both of you. I really appreciate your time today for giving us a little bit more of what is happening in the research for stillbirth, and that there are things that we can participate in for those parents of loss that could contribute to preventing stillbirth in the future. So if you do get approached by Sarah or anybody else in your clinic or when you're being seen, and there is some research going on, think about participating. And then also I wanted to point out that the Shine for Autumn Act this is a really integral time to start getting into your legislature's ears so that they know what that is important to you, to us. And so we'll have a little bit more information on how to contact your legislatures, and so that we can put in a vote, hopefully, so that we can get that funding, so we can kind of start getting a little bit moving the needle on that trend in the United States. So thank you so much. Is there anything else you guys would like to share that I missed, or anything you'd like to say to any of our parents that listen? Because we have a ton of parents of loss that will listen in.
For me, just thank you. I mean, I learn something every day, and I'm always impressed with the strength of these families. And it's just so amazing. Their willingness to participate in research and go the extra mile. It's so amazing. It really, really is. So
I'd also like to express my gratitude to all the families who've been through this. It's really, it's an honor and privilege to work with folks every day, and it's incredibly motivating and incredibly humbling. And it's great that folks are willing to share such intimate and emotional experiences with us and motivate us to do better. And I also want to note that at this time in the United States, stillbirth is having a moment. It's getting a lot of publicity. There's increased research funding. There's increased awareness. There's increased legislation. And that's 100% credit to families and bereaved parents who have been advocates and really helped to move the needle in this country. So thank you.
Thank you so much again. We so appreciate it. And thanks for joining us today on Still a Part of Us.
Great to see you guys. Thank you so much.
good to see you guys. Thank you.